as what was in the presentation, you can see our North Carolina graph of all the counties that we're in. As it was mentioned before, we're in over 50 counties. So we're going to skip that one. One of the things that we did want to talk about is the Behavioral Center of Excellence. I'm sure that you guys have heard about this particular concept, and one of the things that we mentioned is there are 5 key components to being a Behavioral Center of Excellence. Easy access, great, we're going to talk about that today. We're going to talk a little bit about the world-class customer service, some of the data that Peggy had brought up that integrates into that concept. Comprehensive care, you know, how we're talking about integrated health care and how we're going to be able to do it inside of ECHO. That's part of becoming a Behavioral Health Center of Excellence. Then you have excellent outcomes and, of course, excellent value as you're trying to go to your funders, as you're trying to demonstrate data to the public on what's working and what's not working. Those are keys to becoming a Behavioral Health Center of Excellence. So one of the things that Peggy mentioned that we had to come up with is how do we give access to people to services in a shorter time frame? Of course, we all know the answer, open access. See, we're going to roll through these slides. We're going to get into fun stuff. So one of the things that Peggy gave you an overview is what is open access? So what actually happens if somebody walks in? We had 195 people who walked in yesterday, which was the largest that we've had that have come through. Since September, our numbers have just astronomically just increased every single day. And you know, as us as an agency, we're trying to figure out why. You know, what exactly is bringing these people? Because for the last year, we hovered around 150, and then all of a sudden we've just had an explosion. So we tell people, they can come anytime. You know, it doesn't matter. You wake up this morning and go, I'm feeling a little depressed. You know, I need to go talk to somebody. Just come on in. You know, our open access hours are from 8 to 3. We stop at 3 because chances are, as Peggy mentioned, we work to try to get people in and out in 2 hours. I can tell you that's not happening for everybody. Our goal really is to get people in and out in 3 hours is what we're shooting for. I think 2 hours, we'd love it. I think it would be great customer service, but as you know, volume and getting people seen and rolling through the system, you have 195 people. We have 19 offices for people to be seen. Sometimes that's a little difficult, but the alternative is they wait 14, 21 days, 3 months before they ever see a psychiatrist. So we're seeing them same day.
The thing to remember, guys, you know, we're talking about the 2 hour mark that we're trying to hit. We're starting to see 3. You go from 150 people a day to 195 people a day. Peggy already talked about changing some of our business processes and how we could actually enhance what we're doing, how we can get the shuffle going through, how we can get the communication to the doctors a little bit faster, how can we get that clinical record available faster. And I think you got to remember that you're always going to be growing. There's always going to be that ebb and flow of more people, more data, more access. You always got to be willing to change a little bit.
So one of the things, so Scott walks in this morning to our office in Mecklenburg County in Charlotte, North Carolina, if everybody knows Charlotte. He walks in and goes, he'll go to the front desk, he'll talk to the front desk lady and say, I'm here to see someone. Great. The front desk person will give him a triage form that'll just basic demographic information for them to be able to, for us to be able to triage what type of status is he is. Did he come in, is he routine, urgent, or emergent? And that helps us to be able to categorize the individuals. It gives us information for us to be able to give to the clinicians so that they know why you're coming in for today. So Scott gets this triage form. He depends on how long he takes to fill this form out. So it's a short form. He'll return this, and we're going to triage. We're going to look at this triage form and know whether you're routine, urgent, or emergent within 15 minutes. That's our benchmark.
Who looks at that form?
A licensed clinician looks at that form and triage. From that point, we're going to give Scott our comprehensive clinical assessment, the first pages, which was our intake information. He's going to start filling this information out. And this information, we're going to collect our insurance, everything that he's going to need to go ahead and get started in our system. At this particular point during intake, he's actually going to go talk to one of our referral coordinators. So they're going to call the insurance company if there's prior authorization that needs to happen at that point. If they don't have insurance, they're going to go ahead and start. A lot of our managed care organizations will allow us to enroll them in their MCO for covered and uninsured. So start that process and get them enrolled. If they have Medicaid, Medicare, they're going to look at the different sites, make sure, see what their coverage is, and put all that information inside of Echo. That's what happens at the intake piece. Now, for us, that piece needs to happen 20 to 25 minutes is usually what that takes. We'll sign all of our consents and everything electronically at that point at the system, and we'll sit down with the individual before they actually ever go see and talk to the clinician and have a discussion about what to expect. You know, what's your insurance going to be? What are kind of the next steps and what you potentially may or may not have to pay.
So your intake is done by a non-clinician?
That is correct.
Sorry.
No, this is good. That's great. We like it. Remember, it's interactive. We're a family here. We're all Echo family. See, we're all part of the Echo family. From that point, at that point, the next step is they would go and have a comprehensive clinical assessment with a licensed therapist, LPC, licensed clinical social worker. Our expectation, well, I say our expectation is, what we've seen is it takes our therapist roughly about 62 minutes, I think, to do a CCA, was the latest data that I think we saw. And we're hoping that they can do this CCA within an hour. They use, I think I was talking and laughing with somebody about collaborative, concurrent documentation, whatever you want to say. They're doing it during the middle of that session. Currently, we don't have our CCA. Our IT guy hasn't gotten our CCA in the system yet.
Thanks.
But
Just keep digging. Keep digging.
January 1st, 2016, maybe. We'll have it in our system. Because right now we're doing this via paper. So, and it gets keyed into our system. From that point, if medically necessary, then they need to see a doctor same day. They will see a doctor for our psych evals. We want them to see an MD, if at all possible, for that first visit. Our medical director has said that he prefers that be the point of practice for their first time in. And then from that point, they can walk out, like Peggy said, with the necessary scripts. If necessary. Now, we've been successful in a lot of our larger sites, a lot of our urban sites where we've partnered with Genoa Pharmacy, and they've actually come in and put pharmacies on location, so the person could walk right up the stairs in one location in Mecklenburg. They could walk right down the hall and get their prescriptions that same day from that same pharmacy, because a lot of times people will walk out, they may not have resources, they may not go and get their prescriptions filled, and so it's a way for us to partner so that, again, we're getting the people the help that they can need and giving them an opportunity to get their needs met at the same location. So it's really cool. All right. Oh, yep.
So is your psychiatrist reviewing the assessment that was completed?
He is.
So that's going.
And we can talk a little bit about workflow, because it's paper right now. We have a system set up where we use SharePoint. I don't know if you guys have used SharePoint, where currently it gets, because they don't always complete the CCA before the doctor needs to see them. So sometimes it'll get scanned into our electronic health record. It'll display inside of our electronic health record for them to see. Or sometimes it gets sent up to SharePoint if it's not a completed CCA. And then they pull it off and view it so that they have the basic information till the therapist can finish the CCA at that point. So that's how the process works for them to be able to do it. Because, as you can imagine, when you're trying to run people in and out, we always want to make sure that the doctor has the information before he sees them. If they finish the therapist appointment, the doctor's available in 15 minutes after that, which doesn't typically happen, but if it does, we need to be able to get them that CCA for them to be able to review.
Can I just ask, how long do you give your psychiatrist to do their evaluation?
Perfect question. I know Peggy was talking about 15 minutes this morning, but typically, if it's a new doctor, we try to work with them. Most of the doctors come in, their psych evals are used to doing 60-minute psych evals, 45-minute psych evals. Our ultimate goal is to hopefully get it down to a 30-minute psych eval. I can tell you our data says that we're averaging 33 minutes for our psychiatric evaluations. And so, it's a skill set that our doctors have, as they become more and more aware of it, they understand that they want to see as many people and help out as many people there, so they're getting really good at doing a psychiatric
I
evaluation.
think that's a good piece to talk about, though, as far as the training, sometimes training that skill set, and hiring for that skill set. You got some psychiatrists that they want to do that full 1 hour. That's what they're looking for, and that's what Peggy was talking about, where they might not be the right fit for this type of model. So you hire for this model, and you also train for this model. If they've never done it, but you can teach them and they're teachable, then you should be all right.
And is that done on site or is there telemedicine involved?
So it's both. When you have 19 offices and you're trying to see as many people you can, we do rely a lot on telemedicine. But if we have a doctor in Mecklenburg, Charlotte, North Carolina, who may telemedicine to Greensboro, North Carolina, from 10 to 10:30, but then they have somebody who's walked in Charlotte and they're next, and we're going to talk a little bit about Oasis and the flow and kind of how we do that. But if the next walk-in is from Charlotte, they may see them face to face. So it could be either or.
And when you said 33 minutes, that's inclusive of the documenting that service use?
Yeah. It is. Now, that doesn't include the nursing part that happens before. That's actually them sitting in front of the psychiatrist. As you can imagine, anytime when we undertake this type of challenge, there are definitely challenges to workflow. I would be sitting here telling you we have it all figured out, that we're still not tweaking our processes. We're always looking to try to see how we can make things more efficient, better for the psychiatrist, better for the therapist, better for the administrative staff, and looking at ways to how we can do that. So one of the things that we saw when we first started open access is we didn't really have, I know MTM talked about doing open access, but we didn't have an implementation model. So we kind of had to make it up as we went along. Back when we first started this, we do have to integrate with different multiple software. We're going to talk a little bit about Oasis and Echo. Currently, they don't talk to each other. So as you can imagine, we're putting information in two different places, which we're going to talk about our goals and where we're going to go from this point. I'm going to let Jason talk about that. And then the other part that you can imagine is after the triage status, if you walk in and you don't have a good system in place, is how do you navigate 19 different offices with 195 people in here without it just being utter chaos? And so, having to make sure that this individual who has Medicare doesn't go see the LPC, or how do you make sure that this individual who's not credentialed with, Blue Cross Blue Shield doesn't see this individual. So, how are we able to link those individuals to the appropriate staff? And then, like you brought up earlier, how are we going to be able to access the records to be able to review the CCAs, review any pertinent information that we need before we start our treatment? And then let's talk about how we're able to do it. Peggy mentioned Oasis, which is a tool that we developed internally. I would love to give Jason credit for it, but he didn't build it. We have, as Peggy said, we have a great IT team that's even outside of Jason's. Jason will tell you how good his team is. I'm going to tell you how good our IT team is as well.
We're not like the Army. We're not a team of one.
We have different forces within our agency. HR and the electronic health record side, they don't like each other. They're like Air Force and Navy. So we developed this Oasis tool, which it is custom utility. So Jason makes fun of me because I liken it to, and even Peggy said this morning, the airplane terminal model. Now, Jason and I were having a conversation this morning. And I don't know if you guys in the hospitals now, my dad had surgery 2 weeks ago, and it was amazing for me to sit in the emergency room, and they have the screens up now with his number. They only give you what his number is, but it tells you pre-op, tells you in surgery, and it tells you in recovery. That's similar to what we've done inside of Oasis for our staff. There's steps along the way for you to be able to know this person's in screening, this person's in CCA, this person's in psych eval, and then we can track who's where in our system through all of our 19 different sites. That gave us, one of the biggest things was the real-time capabilities. You're not having to call people on the phone all the time and go, is so-and-so at this office, or trying to find. We had to have something that was visually usable for our administrative staff, for our therapists, for our doctors to make this work. So there's the airplane terminal model. And we took a little bit of screenshot on what this looks like. So let me tell you a little bit about the process. Somebody walks in. They get their information keyed in, basic information. And so name, date of birth, medical record number. We go ahead and put that in. We go ahead and start the process in Echo, which we'll talk about how we're going to integrate those two together. And then they go into what we call as the local queue. So we have on-site people who do the intake. We have on-site people who are doing all the demographics, calling the insurance and everything. So think about this. If they're in a local queue, they're only seen at that local site. So if I have somebody in Charlotte that's doing intake, they're only going to be seen by the Charlotte staff. Okay? If I have somebody in Greensboro, they're only going to be seen by them. They're not going to be seen by the entire agency, the 19 other offices. After the screening is done, they get put into what we call as the remote queue. At the remote queue level is when individuals can be picked up by any therapist across the state or any psychiatrist across the state. And what this allows us to do is this particular program allows us to pull data, and I'm gonna jump slides here for just a second so you can see exactly the information that goes in. This allows us to know.
This is like one of the history logs after somebody already went through the system. It gets in some of the data elements where we're trying to figure out how well we're doing, how we're calculating that 33-minute time frame and stuff like that. So you can see based off of, you got their name, what location they went through, how long the screening was it actually completed, who did the screening. So you got Bugs Bunny coming in, was seen by Roger Rabbit. And then the assessment done was done by the amazing Jessica Rabbit. And she did a great job. In 44 minutes, she had the assessment complete. And then, of course, Bugs Bunny had to go see Dr. Seuss. And that was a little trouble for him. He had a couple books written right after that. But he did a great job. He did it in 27 minutes. And from this, we can start seeing these logs. And if somebody comes through and they get halfway through, there's times where they just walk out. And there's times where maybe they don't need a psych eval, and we can start tracking those pieces as well. How long was somebody sitting before they walked out, or how long were they sitting before we determined that they didn't need a psych eval, and we could continue with the rest of the process. And the only way to do that is through the data.
And that's the, go ahead.
Are stats like this used as part of the therapist productivity reports?
So,
yes and no. This gets into different conversations with the operational side. We also have actual productivity reports as to how many assessments somebody's done, how many psych evals somebody's completed. So those are more geared towards the productivity. This gets geared towards how well they're operating, which is a little bit different than
so from an operational side, once a week we get what we call our TPS report, Total People Served report. Right, and it's a productivity report that comes out of all of our therapists, all of our physicians are on this report, and we're able to, we have benchmarks that we need to hit. Typical average is 65% of your time should be billable, which is about 26 hours a week. I have to go back to my finance days. Then it's 26 hours a week. We're asking our therapists to do 27 hours a week. That information comes from Echo. So in our TPS report, based on what they're doing, how long their therapy session is, what they're billing out, that's how it gets added to the productivity piece. As we start talking about integration with inside of Oasis and Echo, that's one of the things that we hope that we're going to be able to do is, you see that assessment's 44 minutes, it was started inside of Oasis. We're hoping that we're going to be able to click a button here in Oasis and it take us into Echo. We're going to go ahead and complete the activity in there, and then it do it. So, and then it go ahead and complete that activity for that assessment. That's big vision. We're going to talk about that in a little bit about where we're hoping to take the two systems, because Oasis is invaluable for our staff to be able to manage this. And one of the best things that we ever did is you hear the complaints. It's too slow. It's too too many things. And you know, one of our IT staff, Jason, will probably tell you about the platform that Oasis was in. It wasn't on the right platform. It was so slow. Our staff were like, I cannot believe you're going to make us enter stuff in Oasis and put stuff in an Echo. I mean, they were beating their heads against the wall trying to figure out and go, we want to get people served. This is taking too much time. And our IT department changed their platform, and it was, the speed was just, you know, they would hit something, they would hit complete on here, and it would take 20, 25 seconds before it would go in. As you can imagine, staff get frustrated. They don't want to use the system. Our data integrity went down the tubes because people stopped putting stuff into Oasis. Soon as we fixed that, and now it takes all of 1 to 2 seconds to put stuff in, it takes no time, and the speed is staff. You talk about customer service. It's not just people coming in to your offices, but it's also your staff. Our staff felt better. They felt more supported. They felt like I can use this system now. I can make it work. So I don't know if I answered your question about productivity, but we don't pull it from Oasis. We do pull it from Echo in our activities. Any other questions about Oasis? I think the next slide's out of Oasis.
No, you're still in more data elements.
Oh, am I still in more data?
Do we share?
We consult.
Yes, consulting is available.
There might be opportunities.
I think this is a fantastic idea. I love this, and I'm going to take this home and talk to the people there about it. And I understand you created this before you were on the Echo system?
Yes.
We did.
So, but now that you are, and you can create your own forms and screens, I would think you could quite easily put this directly into...
Huh. Interesting. I like it quite easily. Jason?
Val, you're supposed to be my teammate for tomorrow, and you're just
Aren't you
digging
on
a
this
grave
team?
for me.
Nice. I have video of you saying quite easily. I'm just saying.
I tell you, you know, that's great. So consulting back and forth. Val, please.
You're right. There's different avenues. That's the great thing about Echo is when we're looking at the product and it does offer us opportunity to do this, so we can make it more efficient. That staff are only having to key it in one time, because as you know, if staff are having to key in something more than once, you lose that data integrity. So, and Oasis is key. I mean, again, we have to have Oasis to make it work.
Go back a couple screens to the queue where it shows the queues.
You put all those in.
So one of the nice things about Oasis, it's a little bit different than what I can do currently in the VHR, is the queue. And now there's a dashboard that's coming up to be able to see multiple schedules, multiple people's schedules. VHR is very client-centric. It's based on that one client. There's changes that are happening. And yes, I can see a form that I've created, but I can't see that across multiple places and multiple things. This gives me that access. I mean, I was just talking with Alan about it, earlier, the platform that it's built on. It's a Java-based platform. It's not running currently on Tomcat, but it can run on Tomcat. So there's those integration pieces that we can still do, and we're still working on. I was working last night with Carolyn Spence from Alexander. We were talking about where we are now with the system and how to integrate some of these pieces. And we were talking about making like a check-in form, a check-out form, and then maybe a logs, not separate forms, but actually the same form, but just tabular. And seeing how we can start passing the information back and forth, because there's certain things in here that I really like about how it's set up, because it's that monitored view that can go across multiple screens, kind of like you were talking about in the hospital, or maybe you're in Verizon and you're 10th in line. Well, all that is so clean and pretty right now. It's not conducive for me to try and rebuild all that stuff inside CDT, but it is conducive for me to start pushing that data back and forth so that I don't have to have somebody clicking here and then clicking again in CDT. I want to make it where when the click goes in Oasis, the stored procedure runs to populate that data inside CDT and vice versa, so it's more real time. Sure. Awesome. That's the beauty of peer-to-peer.
Yes, exactly. We appreciate, Jason appreciates all the help he can get. So one of the cool things about in Oasis is the data that comes out of it. And so one of the things, as you can see, we can track exactly the hours when people come in. So 80% of the people come in between 8 and noon. Makes sense. People come in the morning, they figure they have a better shot of getting seen. You have 195 people walk in. You know, we have people waiting in the door, in the lobby at 7:30. That tells you kind of they're desperate to get help. They are showing up at 7:30, waiting in the lobby because they know the doors open at 8 because they want to get seen. So this is part of the data that we actually pull out of Oasis, is when people come in, that we're going to morph into being able to get in inside of Echo. We're also able to track definitely the number of days. As Peggy was talking about, our business analyst looks at the days when people are coming in. We're currently working on revamping. I know Daniel's gonna yell at me for this one, but we're currently working on a way for us to be able to forecast our staffing structure per days with their PTO time and different things to understand what our volume is that we're gonna be able to handle on a particular day. We're pulling that data out of Echo based on the schedules that we actually put inside of Echo for our therapists and for our doctors.
So I like this slide. I'm looking at it and I see Monday and Tuesday are around 20% and Wednesday's 21%, and we were talking like 21%, 1 more percent. That's not a big deal. When you start thinking about the volume of people that's coming through, 1% can equal 10 more people that walk through the door, or 100 more people that walk through the door. That 100 more people that's walking through the door, how many more therapists or psychiatrists do you have to have on site or via the telemed to actually handle that? That 1% is huge. And you get down to Fridays, okay, good. You start analyzing, this is where the QM side comes in, like, why are people not wanting to come in on Friday? You know, is it because they don't want to mess up their weekend? Maybe they handle our stuff in Monday. And why is it Wednesday? What is it about a Wednesday that people are coming in? Is it hump day that they can't get past the middle of the week? I don't know. That's that QM side. I'm not QM. Somebody else has to analyze that piece. But as far as the data side, that 1% can be huge as far as your staffing requirements.
And we typically see it fluctuate Monday, Tuesday, Wednesday. They all kind of interchange who's the top percentage of individuals. One of the data points that Peggy mentioned this morning that we do take is we have a survey on an iPad. So somebody finishes their service for today. When they're getting ready to check out, they're given an iPad where they can anonymously take. It's an 8-question survey. They don't have to do it. We encourage them to, because that's how we get our feedback to know how we're doing with our services and everything. So one of the questions that we asked is, if Monarch did not have an open access center, I would have received my services from. And then as she talked about this morning, 25% of those people would have gone to the emergency department. So we had 200 people who showed up yesterday. So 25% of those individuals on average, which is typically on average what we see, would have said that they would have gone to the emergency department.
We used to talk about how much does it cost for one person to go to the emergency department. What was it, $2,000, $2,500?
$2,100, $2,400, something like
So
that.
each time somebody goes into the emergency department, it's a couple $1,000s per visit. So when they come through our agency, that's a couple $1,000s saved. All right, so that's money that's back in the system to see more people. So when Peggy was talking about the money is there, as long as a whole in a collective group, we use it the right way, that's part of it.
And also what we do know is 32% of people would not have gotten services anywhere. That's an alarming amount. Those people would have sat at home. They would have potentially gotten worse. They would have potentially ended up in the emergency department.
That's a scary number. 32% without this would have got no service. So imagine your car's broken. You go take it to the auto mechanic and you can't get an appointment, so you keep driving that broke car. Then you try and go to set up another appointment. I can't see it for a couple of months. Got to have that car. So keep driving that car. Eventually, you keep driving that broke car, it completely breaks. Your body, mind, and spirit's the same way. You keep pushing through and without being seen, without getting some help for any issues you're going through, you eventually break. And that's that 32% leads into that breaking piece. That's scary.
So this goes back to that Behavioral Health Center of Excellence that we talked about in the beginning, easy access. So we're providing them access to services. Another part that was part of the Behavioral Health Center of Excellence was customer service. Now, I take pride in the fact that 98% of the people were treated with courtesy and respect. I would love to have it at 100%. You're always going to make some people unhappy, unfortunately, but we do our best. We have customer service training that we're currently developing even more with our front desk staff, because that front desk, I can't stress enough that front desk person needs to be your most vibrant, needs to be, because that's going to be their first point of contact, is that person when they walk in. So if you have somebody who doesn't have personality, who doesn't relate to the individuals who come in and gives them that feel good, the individual's going to have a bad taste in their mouth when they first walk in. So from an operational side, that's a huge component. And it's more invaluable than I think you put money on that. We've found success with having those people that can relate well with the individuals. The one that I think that we as an agency are working towards, that I know Peggy said 86% of the people receive their services in the reasonable amount of time. We'd love to see that number go up even more. Again, we want people to receive services. We want 2 hours. That would be great for every single person who walks in. Imagine you feel good. You see a therapist for your comprehensive clinical assessment. You have your psych eval. You're out in 2 hours. How good would you feel? So this is something as an agency that we're working through on trying to figure out how we can ever increase our efficiencies, whether it's capacity or what we can do, so we can see people quicker and get them through. Because again, it's customer service, about experience. You asked about the productivity. Since we started open access, Jason cut my graph off. I had a lot bigger, but it was a lot smaller. So we've seen nothing but an increase in productivity for our therapists, especially for our LCSWs, because they can telemed out. It's easier for them to hit productivity if they have a no-show, if they're an established therapist. So somebody walks in, they have a no-show, therapist jumps on Oasis, they pull somebody down, they do CCA when, instead of sitting there for an hour because they had a no-show, they're able to actually get somebody seen that day. Doctors are the same way.
So after someone has gone through this open access process, what happens to them after that point? Like if they were already an established patient of another psychiatrist but they couldn't get in to see them, or if they already had established therapist, what happens after that point?
So, I got this.
No, I was going to talk. But you go ahead. No,
I'm not the operational guy.
You go jump in. I was letting you talk on it. You look like you want to talk, so go ahead.
No, the product is, or the queue is set up so that it's walk in. So if you're not an established patient, but we also, if you are an established patient but you can't get that appointment, yes, you come back in. But that next appointment is scheduled. It's that first one that we're going through that we're saying just walk in the door so we can get you through. But if you are established, yeah, come on through if you can't make that appointment. We're going to set up the next appointment for you, though, so that you have a schedule to go by after that. Yeah.
Have you looked at retention afterwards? One of the things that we struggle with is everyone demanding psychiatric appointments from the moment they walk in, and so it's a very valuable resource. And trying to get those appointments. Do you have retention in services after that? Are they coming back and actually seeing the therapist?
We do. I wish I had numbers for you. I thought about it this morning and wish I had brought those numbers with me to give to you. I think along with other agencies, we struggle with trying to also keep them engaged, and we're looking at ways. We've hired engagement specialists in some of our locations that kind of hammer home, you have a therapy appointment coming up, or you really need to be for your med check appointment and such. So I wish I had numbers. I can get you numbers on what our data shows to see if it matches. But we also use clientele. I don't know if you've heard those as a reminder calls. They go out 48 hours before their next scheduled appointment. We're currently looking at the texting option, because I think there was some data that said 90% of the people in America have cell phones, smartphones, but they don't have home phones for the follow-up phone call. So we're looking at different ways to do exactly what you said, better engage, and to create awareness for them to come to their follow-up appointments. I don't have those numbers, but I can get your information.
And are you offering, so the person says, no, I just want psychiatry, I'm not really interested in any other services, are you offering psychiatry only? Like in our state, that would be like a major doctor who lose money in every psychiatric appointment.
We do have some individuals, the doctors are the ones who really push the therapy. So if they have somebody who's med check only, our doctors will say you really also need to be in therapy, and they work with the therapist, they work with the individual to say you really need to start coming for your therapy appointments. But we do have individuals who are med check only that come through. I don't know what the percentage is, but.
Okay, I got another question. Sure. So also, someone comes in, they see the psychiatrist, they're prescribed a simple antidepressant. I mean, are they always following up with the psychiatrist, or are they following up with their primary care physician who would be really capable of managing that med?
So I know, typically when they come in, they go to MD to come in. They see somebody. Typically their follow-up services are with the nurse practitioner. They can either be, currently we have family nurse practitioners and psychiatric nurse practitioners, depending on, I think that's on a case-by-case basis, whether they're going to follow up with their PCP or whether they come back with us on that follow-up. But, their follow-up services are usually with a nurse practitioner. We do, I know North Carolina is changing their laws about the family nurse practitioner, but we do have a lot of family nurse practitioners in our offices currently for that follow-up service.
So are you finding you're needing to continually add capacity for your psychiatric services as a result? Because you're bringing in a lot of people. I mean, it's like we've had open access system, but we haven't made psychiatry part of it because there's just not psychiatric access. There's not enough psychiatrists in our area to serve them. Consequently, most people aren't seeing a psychiatrist for psychotropic meds. They're seeing a primary care doctor and a psychiatrist for seeing people who are more complex. So are you continually filling that pool of psychiatry then in order to continually absorb these folks that are coming in?
We are, but we're also looking at, operational wise in business workflows, how to get people through faster. And that's one, you got to do both. It can't just be you keep throwing people at it, because if you got the psychiatrist sitting there waiting 40 minutes for paperwork to come through or for a no-show that happened, that's wasted time where people could actually made it through. So you got to do both. You got to look at the workflows, how to tighten those pieces up, how to tighten up your business processes, as well as look at, do you need to keep adding capacity for your psychiatrist?
And for us, managed care organizations won't open access, not just to include them to see the therapist, but they also want them to include to see the psychiatrist. So we've been able to go in and negotiate different types of contracts so that we can see individuals, because your concern is a very valid one as far as money and how to make it work, because we all know the rates don't necessarily support the service that they're providing. So it's leverage for you to go in and be able to say, I'm providing open access, here's what I can give you. I'm going to need 2 psychiatrists or whatever it is, and work with whoever your funder is to see if we can figure out how to make it work. And we've been successful in a number of different counties to be able to do that. So we talked about all those great things. We're still missing things. Some of the things we've already talked about is the timely access to the electronic health record. Because Oasis wasn't integrated with the health record, we definitely had issues with data integrity. Our data from Oasis doesn't match our data in Echo all the time. Single data entry, again, we all want to just key it in once. That's efficiency, efficiency, efficiency. And we talk about efficiency of processes. So I'm going to let Mr. Cagle talk for a while I drink some water about what our next steps are.
There you go. Pass the torch. All right, which button do I press? There we go. All right, so integrating Oasis with our electronic health record. Let's see if we can go this way. So one of the pieces is who's on the team. Peggy was kind of alluding to this today, and what we talked about, we brought in a process analyst guy who knew absolutely nothing about clinical. Why is he on the team? It's kind of weird, Why is an IT guy on the team to talk about clinical development, clinical processes? Why is finance on the team? Why is QM on the team? All these people that you think, oh, they shouldn't be on the team. They absolutely should be on the team. One of the partners that we seem to forget sometimes is who else should be on the team. Your other partners, your other providers, your software vendors. What can they do? What do they already have in place? I'm going to start picking on Val a little bit because she's sitting in the back and already she's got some ideas about how to do some of this integration that I'm looking to do. That's amazing. I like it. She's going to be on the team. Matter of fact, tomorrow at the Help Desk Challenge, she is on my team.
Well, and the cool thing talking about who's on the team is I think even your clinical staff need to be challenged on using the system, especially electronic health record, thinking through the system. You know, I know clinicians want to be clinicians, they want to see people, but that's how you make it better. And so operationally, you know, we bring Jason ideas all the time that he yells at us, I can't do that. And I'm like, yes, you can do it. You can do anything. I don't care what you say, anything can happen. And so I think challenging your staff to figure out ways to make it even more efficient and taking their ideas and seeing what works and makes sense and workflows, and then of course testing before you roll something out.
This workflows is huge. I mean, that's what's allowed us to grow as fast as we have. It's changing a lot of those workflows. Workflows are both your just paper shuffling to people shuffling to data shuffling. It's all part of the process. Your reports that we can get out of the system, you saw like the logs that we were looking at and how we're trying to analyze that data to see how do we need to staff a little bit different, how effective are our clinicians and our psychiatrists at actually seeing people appropriately in an appropriate amount of time, how effective is our front desk staff and getting people in the door completely checked in, how well are we doing triages. That's all in our reports. I'm going to show you one of the reports that we have in CDT right now. It's actually, well, not in CDT, but it comes from CDT. This is our intake air report. We also call it the DIR, the Dirty Intake Report. And it really starts to tell us, like Chris was talking about, the Oasis piece was developed before we had Echo, right? So they're putting in the person's name, the person's date of birth, their insurance, they're filling all those different pieces out. Then they go fill it in again once they get into the electronic health record. So as you know, that dual documentation and triple documentation means missing documentation. And so we try and check those pieces on the front end. And you guys will all notice it's like guarantor missing from pay source, policy number contains special characters. Well, the back end billing, sure, that checks that. I don't like that. I don't want it to be checked on the back end and when I'm trying to create an 837 and push it out the door. I want that checked on the front end where somebody who is right there in front of the person we're supporting to get that information, who had that front-hand experience, who still has the paperwork if it's paperwork, or still has the identification cards if it's right there, to get this information in before it ever goes into the financial side. Yes, ma'am?
So because you're having to do basically double the work for your front desk staff having to do that double information, how is that affecting your billing? Because if we pull from revenue manager in order to do your billing out into the world, but somebody missed something that we may not catch on that side, how is that affecting how you're getting paid? You're doing a lot of business at a high volume at a quick rate, and I couldn't imagine how many errors that you might be getting.
It's hard to imagine for us sometimes why there are so many errors.
Oh, wow, Jason. So he's getting ready to show you on the next slide a really cool tool that he developed that is exactly what we're catching it on the front end and correcting it in the field before it ever even gets to your billing processes.
So you got a couple things that are happening. You have the intake that's going on, and then you have the actual activities that are being created. We bill off the activities, right? So sometimes intakes happen, and then they don't get completed because maybe the person walked out and decided they didn't want to stay any longer. They just wanted to get out, right? So there's no activity on that, but the intake's also not complete. So we created the separation between the reports, but the way we work them is from our activity error report, also called our DAR, Dirty Activity Report.
We're original.
So the thing about this is just a summary. And what's nice about this is that managerial view to kind of see where we are and how we're doing, to know that we have an error count currently of 119 activities missing a diagnosis. Now what's significant about that is we do diagnoses in our system a little bit different than a lot of people that use CDT. We put the diagnosis directly on the activity. A lot of you guys, I think, do the diagnosis just inside the diagnosis screen. Maybe you use some limiting criteria and stuff like that, where our clinicians wanted to be able to say, I'm working on that diagnosis. And a lot of that came from like dual diagnosis for like substance abuse and mental health. And so you have your substance abuse clinician. She wants to say, I absolutely want to document that I'm working on this substance abuse diagnosis. And so by doing it the way we do it, it allows them to do that. They feel a little more comfortable saying what they're working on. However, sometimes they still forget to put it on the activity. If it's not on the activity, it doesn't go out on the bill the way we want it to go on. The next one, like this note missing signature, we got 69 activities, note missing signature. George was showing yesterday his new fancy dashboards. One of the dashboards was about how long did it take a clinician to sign the activity, right? I understand why that's a problem. You put your note in and right away you sign it. I'm not sure what the struggle is, but also I'm not a clinician. I'm a techie guy thinking that you just click, click, click. I don't have somebody in my face that's going through some emotional roller coaster and then somebody outside the door waiting to come in too because I have 195 people walking through the door. I'm not that guy. I'm the guy looking at this, come on, sign this thing. What's the problem? And then at the same time, trying to create some better workflows so that they can sign it easier so it's a little bit less clicking.
So the cool thing about that is this is a report that comes out every single day. Our practice managers get it for all of our locations, and they send it out to the necessary parties to clean up any errors that are on there. So this is a daily report that's run so that we can catch these real time and that we can not impact billing. Because if it's on this report, it's not going to billing until it goes. Sure.
I'm brand new to this, so I haven't even learned the system.
Okay.
But
We've been there.
We haven't learned it either.
Well, like these particular things that you have listed, are these standard things already set up in the clinician's desktop to be flagged? Well, you guys had to write code. In other words, you analyze the information in the clinician's desktop, and you specifically wrote the
Yes.
code to
So
identify these things.
I'm gonna say yes and no. Let me go back a slide. When we get into things like this, like some of this billing information, inside the 837 configuration screens, there's some error checkers that are great error checkers, right? So if you run that before you run your 837s, it'll catch a lot of things. And what it does, it locks down those particular activities, and then you got to look at the report, and then you got to go work them. That workflow didn't work for us because at that point it was already in the revenue manager side. The clinicians couldn't really deal with it. It's already been processed, and then so you have to sometimes possibly do some reprocessing. I didn't want to mess with that either. And so we took a lot of those errors that we saw were a struggle, and we built our dirty activity report, which each one of those were coded in, and so that we could highlight the exact errors that we wanted to focus on.
So in other words, with the standard Echo, like clinician's desktop, I can't configure it to give me this. I would need to, like you guys have taken that, like whatever's in there and created this system.
Correct.
Yeah.
But I think that's the cool thing about Echo is it's customizable for you to be able to do it because not every agency is built the same.
And there are ways that you can create error messages to pop up when they're internet.
Really?
Like if they didn't do a diagnosis.
Huh? Really?
Another one of my teammates. Teammate one, teammate two.
This is why
Dig,
I come to this conference
dig.
so I can see if Jason's telling me the truth or not.
Oh my gosh.
There are ways that you can go in and set up that activity to pop up an error.
Oh, and it will hold it. If you have an issue with it's gonna hold it in the system on our end. I'm the revenue cycle management, so it's gonna hold it on my end. It's gonna say we can't do anything with this until you fix whatever's wrong with it. And we send it back to the office and we ask for a correct diagnosis or a correct admit time or whatever it is that's missing. But it holds all, and we will hold an entire batch.
But do you have to fix that yourself? Do they send you the information?
I have some clients that send it to me fixed. I have some clients that fix it themselves. I have some clients where it's a two-way street where we both fix stuff.
So did they go into RevMan to fix it?
But you have to hold the batch. You have to hold the batch.
But I have, well, what I do is I separate out. If it's a small batch, sometimes I will separate out and let everything else that's ready go and then hold on. If it's big batch, I'm gonna be annoying, and I'm gonna email, and I'm gonna call, and I'm gonna do whatever I need to do to make sure that those bills aren't holding, because I want everybody to be ready.
And this is where your workflow and your work volume is a factor. And so the way we wanted to do it is we knew our clinicians or our intake staff were the right people to handle these errors. And so we didn't want it to be tagged and processed on the other side. And so the way we work this is we don't allow anybody to tag, right? Only my automated system can tag. And so what we'll do, we run this DAR checker, right, to see what's missing, what errors, and then the automatic tagger goes through and it says, all right, is this activity flagged for being on the DAR? If it is flagged, it doesn't get tagged. As soon as it runs through and sees that it's not on the DAR, it'll tag, and then our finance group can actually post it over from CDT to revenue manager and process it. Because one of the things that I didn't want to do is every time if something is messed up on the activity and it's pushed over to the revenue manager side, in order to fix it, half the time you have to reprocess it or push it back to the CDT side. I didn't like that. It wasn't effective for us because of our volume. And I don't know how effective it is for you guys' volume, but it wasn't for us. And so our idea was to put those errors checked on the front end, and so our finance folks could just continue to go. Because as soon as they stop, they're dealing with some complex stuff. Not that the clinical side is not complex, but when you have a $300,000 RA that just came back, half the stuff is messed up because the RA doesn't match the check, which doesn't match the 835. It's tough to deal with. And at the same time, you're trying to reprocess those servers, to back out charges, to do recoupments, and you're trying to chase somebody down to put a diagnosis in there and put the policy number and the guarantor. I feel for you. I understand when you said you're going to be annoying. You absolutely have to be, but I don't want my people to be that way.
So how are you able to utilize this closer to intake so that perhaps if the person is still there, you can get it corrected while they're still available to you? Are you able to do that?
No, it comes out the next day, but we scan all the information in using image CST data, image silo, so they can go back and look at the image
I got this, and we are working on that. I got this. So when
I wasn't complicated enough. Hold on, let me come over here and sit. I was trying to make it simple for you.
Karen was talking about validations and stuff like that. There are some pretty cool ways to do validations, and you can get really serious with it. If you make an intake form, you can set up a validation list on every single field. You can put a stored procedure on a button to do validations to make sure, one, that all the fields were entered and that all the fields were entered with the correct information. Then you can say, once that stored procedure comes back with a positive of yes, okay, now let the intake go through and create the charge. You have to build that. It takes time.
That you can do in Echo? Or is this something, again, in the clinician's desktop, that kind of thing?
You can, but you're also looking at performance-wise. So here's the other thing that you look at, right? 195 people walking in, right? 195 people walking in. You gotta keep moving, right? So as soon as we slow down, the run through 30 validation checks because I'm missing this, then that line starts backing up out the door. So we don't want to do that. So instead, what we want to do is actually let them continue on through. These errors will come up. Now, what you're seeing is actually just the summary. There's a more detailed report. This comes out by locations. We got 100 and something locations. The errors are actually tracked by locations. There's practice managers or program managers that push those errors to be fixed. This is the summarized report that feeds out to my boss and his managers as well to give them a better understanding of how well they're doing. And so there's a lot of structure that's in place.
Well, the cool thing, because I know we're running short on time, is we have currently the lowest denial rate from our billers that we've ever had. I think it's 8%? 8% denial rate. So we're trying to incorporate any new catches or any new things that we can do on the front end to even lessen that. We want to get within lower than 5% denial rate. So, it's definitely a tool that it's a benefit to our agency.
That's the thing about Echo or CDT as well as Revenue Manager itself is it's customizable. You know, it's like Karen's got an idea how to do something, Val's got an idea how to do something, I have an idea how to do something, he has an idea how to do something. And, you know how viable that idea might be, that's you know, don't worry about that. But the fact is the system is customizable. We have software that we built outside the system that we're now working to integrate inside the system. We have reporting and store procedures that's running to send out these error checks and validations that's actually running in the system to make the system run better. So the thing to think about is you don't ever want to buy software that you're locked in to how it works. You can't do anything with it. So you have to drive that road no matter how bumpy or ugly it is. I don't like that. I want to be able to change things and work things our way and make it where the software conforms to our business. Because we all have different ideas of how to run it. Every question out here is like, hey, we do our stuff this way. Because everybody has a different idea of how to do their things. And that's why we let that go. So, where are we? That's me. Right there. You know, every day, that's me.
Y'all feel free. Hold on.
No, seriously. You know, the pieces that we still got to work on is finalizing some of that integration between Oasis and CDT. And we're working through that strategy and through that structure right now. It was definitely designed outside the system before we ever had Echo. I wanted to get some of those business processes tightened up before we truly start building screens, because I don't want to build stuff and then got to rebuild and rebuild and rebuild. So we want to think through it, but what I don't want to do is have that whole paralysis by analysis where we never get anywhere. We got to move forward. We got to start with something. So we got to analyze these data elements. We got to make some real-time business decisions. We got to get some measurable benchmarks. We talked about the reports that we're doing now, how we're seeing if somebody's coming in on this day, what the time frames are. Now we really got to get to those outcomes. That's it. Any questions?